Hello everyone. So yeah, this is the second video I'm uploading in this few short period. So this is a video about how I done managed to do the second vertical chop in this patient. So till now, and also in this video, I will also demonstrate in my style of how I give Alcon 3 pins lens without any financial interest. So till now, I have stained the intercapsule. The patient is been operated in topical anesthesia of NS23 grade cataract, and after staining the intercapsule, and then I put visco uh, to fill up the intercapsule, and I also covered the cornea with the visco to give a better visualization. So the rexis uh, is the most important part sometimes in the cataract surgery, because if somehow the axis become discontinuous or it's not circular, then uh, the surgeon have to change the procedure, which is not normal. So somehow the axis is circular around 5.5 to 5 mm. So again, the traprenal incision of the main corneal wound has been done. So I'm doing the case in temporal section. I made the temporal section incision, though I'm sitting in the superior temporal part of the patient, but I made a case in this temporal section, and I've made two side ports on 180-degree apart, so that the outcome come out to be the astigmatic neutral. So that's why I've decided to do two side ports 180-degree apart. Now this side port making 180-degree apart, that means 90 degree from the main incision, can cause sometimes problem in the vertical chop. So I used Kelvin tip, which is in the Chaksu CX3 Faco machine with no fine centimeters again. So again, I do the initial cleaning of the cortical matter. Then once I inserted, looks I try to make the vertical chop with the chopper in my left hand, but it's not getting complete. So then I again make another chop with the second attempt, and somehow, yeah, the chop has been done. But uh, that makes me some delusional. But I thought the chop has been completely done, but there was some problem. Improper chop was there, but it has done finally. So I have taken not half part of the nucleus, but around one third part of the nucleus. So again, I lifted by lollipop technique and made another small chops with my vertical chopper, and finally, in the last part of the nucleus, when I'm chopping, I was controlling my foot pedal so that it will create less surge, and it will save the posterior capsule. And with my help of the my left hand, I'm bringing all the remaining nucleus to the center of the tip, and the entire chop has been done. So finally, after creating after making entire phaco, and that chop has been done. So as you can notice in the posterior behind the posterior capsule, there's one filament type of things is present. So it's nothing but PVD, I guess, which was not visible when the cataract was there. But since the cataract has been removed, that PVD has been clearly get visible. So after cleaning the one side of the cortex, now I'm shifting to another side, and cleaning the rest of the cortical matter from both the sides. And after removing the last part of the cortex, now I will do the final cleaning of the posterior capsule. So it will clean the few epithelial cell migration, and it will cause less chance of PCO. Now, uh, forming the uh, capsule again, forming the chamber again with visco, and now for inserting 3-piece. So first I uh, fill up the cartridge with visco and take the 3-piece lens, wash it, and put above 1 drop of visco. Then again I insert it in the cassette, in the cartridge, and the trailing haptic is to be put at the back side of one the tube, which is visible there, which causes it easy to fix in that cartridge. Now, after pushing it at the main edge, now as you can see, um, sometimes it becomes problem on putting the lens in the back. So after enlarging a bit uh, of the main entry, which was from 2.8 to just around 3 entry, I insert the tip. So holding, fixing with the repositor, I very slowly put the leading haptic, and with the respect of the leading haptic, I rotate my cartridge, and it goes in the back, but not fully. So I can take the dialer, rotate it back, and then slowly I rotate the trailing haptic in the back, and it finally goes inside the bag without causing any major issues. So I again check whether it's in the bag or not, and it's finally put in the bag without any uh, disruption of the interior chamber. So final visco wash is done, and cleaning has been done. So I was not going under the lens, because I was trying but not going, because the people is small, and but somehow I made, but not making the stunt again, because people is small, it can cause stretch in the jonules. So just tapped it and removed the visco. Final closing of the wound was there. uh, the hydration was around the most in the superior part of the cornea and the scleral side, so it causes less white opacity in the cornea. And main wound closing is not so important, but still I sometimes does it. But in here, the chamber was formed and the case was finished, and just final check was done to see any other problems there. But then I again closed the vein wound, and the case was finished. Thank you.